Imagine you wake up one morning, and you swallow just a totally standard over-the-counter pill to deal with a minor annoyance, like maybe a little congestion or a slight ache.
Right, just a totally normal routine.
Exactly, you just go about your day. But because of that pill, a few hours later you walk outside, the sunlight hits your skin, and within minutes you start developing a severe, blistering sunburn from the inside out.
Wow. Yeah, or, let's look at another scenario. You take an allergy medication, it makes you a bit drowsy, which, you expect.
Yeah, allergy meds always do that.
Right, but that drowsiness escalates into severe neurological confusion.
Hmm.
It causes you to lose your balance, fall down a flight of stairs, and fracture your femur.
Oh man, that's a nightmare.
It is. But in both of those scenarios, the medicine did exactly what it was chemically engineered to do. Your unique biology just turned that chemical engineering into a catastrophe.
And that is why we're here today. Welcome to today's deep dive. We are stepping out of the clean, precise world of broken bones and predictable X-rays and wading straight into the murky, highly volatile waters of pharmacology.
It is definitely murky.
Today we're focusing on something you interact with all the time, probably without even a second thought. You pop a pill for a headache, you take a course of antibiotics, you manage your blood pressure.
Yeah, it's just part of modern life.
But we are pulling back the curtain on the incredible clinical work of Dr. Manoj Kumar, MY, alongside Dr. Basavana, PL. We're decoding the incredibly complex world of adverse drug reactions, or ADRs.
And, just as importantly, we are exploring the massive global detective network that exists purely to keep your medicine cabinet safe because, medicines are profoundly powerful tools.
Right. They cure things that used to be guaranteed death sentences.
Exactly. But they're double-edged swords. The fundamental philosophy we want you to adopt today is that every single time you introduce a synthetic chemical into your body, you are initiating a complex, high-stakes biological negotiation.
A biological negotiation. I like that.
Yeah.
So our mission today is to help you move from being a passive consumer of medicine, someone who just swallows a capsule and hopes for the best, to an active, informed participant in your own health.
That's the goal.
To establish the sheer scale of the stakes here, I want to highlight a statistic from this clinical research that frankly just stopped me in my tracks. Approximately 5 to 10% of all hospital admissions are due to adverse drug reactions.
Yeah, that number is huge.
And it gets worse.
Yeah.
Once patients are actually admitted into the hospital, 10 to 20% of them will experience a severe reaction to the drugs they are given while in care.
It's a staggering reality. We're dedicating a massive portion of our global healthcare resources entirely to managing the unintended consequences of the very things we're using to heal people.
It's like a hidden epidemic.
It really is. It's a hidden epidemic of morbidity and mortality.
So we need to understand how this happens. And to understand the scope of the problem, we first have to agree on what the problem actually is. People throw around terms like side effect and adverse effect and allergic reaction interchangeably. I know I do it.
Oh, everyone does. But in the medical lexicon, there is a very strict, very crucial distinction between these terms. Precision of language is everything here.
Right, because if global health organizations are going to track these issues, they have to be speaking the exact same language.
Exactly. We have to clearly separate three distinct terms: the adverse effect, the adverse drug reaction, and the adverse drug event. Let's start with the adverse effect, or AE.
Okay, AE. Let's break that down.
An adverse effect is a very broad drug-centered term. The definition is any unintended and undesirable effect of a drug occurring at normal therapeutic doses.
Okay, so normal doses, just unwanted stuff.
Right. The focus here is entirely on the chemical itself.
Yeah.
The question the medical community asks is, what unwanted things can this specific chemical compound do in a biological system?
So it's basically the whole laundry list of things that could go wrong.
It encompasses everything. But importantly, not every adverse effect is formally reported to safety databases because many of them are just well-known nuisances.
So it's broad. The drug is the main character. What about the adverse drug reaction, the ADR?
ADR is a narrow, patient-centered term. It is specifically defined as a noxious and unintended response to a drug occurring at normal doses used for prophylaxis, diagnosis, or therapy.
The word noxious is the pivot point there, isn't it?
Exactly. Noxious means actively harmful, poisonous, or severely unpleasant.
Hmm.
While an AE asks what the drug is capable of doing, an ADR asks what specific harmful reaction did this individual patient experience because of the drug.
I see.
It is a subset of adverse effects. These are the serious clinical issues that actually get reported to pharmacovigilance networks.
Let me try to put an analogy on this to see if I'm tracking the difference. An adverse effect, an AE, is like an automobile that has a feature where it beeps loudly every time you open the door.
Okay, yeah.
It's an unintended, perhaps undesirable feature of the car's electrical design. It's just a general effect of the machine. An adverse drug reaction, an ADR, is if that loud beep is so piercing and specifically pitched that it actually damages your eardrum.
That is a perfect way to visualize it.
So one is just a trait of the machine, the other is a noxious, harmful reaction happening specifically to you, the driver.
Precisely. The golden rule in pharmacology is that all ADRs are AEs, but not all AEs are ADRs.
That makes a lot of sense.
A dry mouth is an adverse effect. Liver failure is an adverse drug reaction.
Got it. But the clinical framework escalates this even further. There is a third term, the ADE, or adverse drug event.
Yes, an ADE is defined as any untoward medical occurrence that happens during treatment with a drug, whether or not it is directly, chemically caused by the drug itself.
Wait, whether or not it is caused by the drug? If the drug didn't cause it, why are we blaming the drug? That sounds like, I don't know, a legal loophole.
It's not about blame, it's about context and downstream consequences. Dr. Manoj Kumar's work provides a brilliant, highly specific clinical cascade to illustrate this.
Oh, awesome. Let's walk through it.
Imagine a patient who suffers from allergic rhinitis, so severe chronic allergies. Their physician prescribes a very common antihistamine called chlorpheniramine, specifically a 4 milligram dose. You probably know this as CPM.
Okay, so they take the antihistamine. Now, I know from personal experience, those old school antihistamines make you incredibly sleepy.
Precisely. CPM is a first-generation antihistamine. It's highly lipophilic, meaning it easily crosses the blood-brain barrier.
Ah, so it gets straight into the brain.
It does. Once inside the brain, it blocks H1 receptors, which are partially responsible for keeping you awake and alert. So the patient takes a pill and gets drowsy. That drowsiness is the adverse effect of the AE.
Because it's a known, unintended pharmacological consequence at a normal dose.
Right. Annoying, but expected. But let's say in this specific patient, perhaps because of their age or how their liver metabolizes the chemical, that drowsiness becomes extraordinarily severe.
Like they can't stay awake at all.
Worse, it escalates into acute neurological confusion and disorientation. It is now a noxious, harmful response happening specifically to their biology.
Okay, so that severe confusion is the adverse drug reaction, the ADR. It crossed the line from a general known annoyance to a specific harmful crisis for that individual.
It did.
Yeah.
Now, because this patient is severely disoriented and confused in their own home, they stumble, they lose their footing, they fall down a flight of stairs, and they sustain a complex bone fracture.
Right, which we talked about in the intro.
Yeah, that bone fracture, the physical, mechanical trauma resulting from the cascade of events that is the adverse drug event, the ADE.
Oh, I see. So the chemical compound didn't snap the bone. The stairs snapped the bone, but the bone would never have snapped if the chemical hadn't compromised the patient's neurological state.
Exactly. The drug caused the AE, which intensified into an ADR, which created the environmental conditions for the ADE.
That is fascinating.
If a pharmacologist only looks at the chemical mechanism of the pill, they miss the reality of patient care. You have to look at the entire context of the patient's life.
That distinction makes complete sense. But it naturally leads to the next massive question. We know what these reactions are now, but why do they happen to some people and not others?
That's the million-dollar question.
I mean, why does one person just take the allergy pill and take a nice nap, while another person gets so cognitively impaired they end up in the emergency room with a broken leg?
To understand that, we have to look at the anatomy of vulnerability. Why are certain human bodies fundamentally incompatible with certain chemical compounds?
And the clinical data breaks these risk factors down, right?
Yes, into two main categories: patient-related factors and drug-related factors.
Let's start with us, the patient-related factors. Who is actually at the highest risk when they open a pill bottle?
The demographic data is very clear.
Yeah.
The highest risk populations are the elderly, pediatric patients, so neonates and infants, females, pregnant individuals, people with specific genetic predispositions, anyone with a previous history of an allergy, and crucially, patients with renal impairment, hepatic dysfunction, and multiple comorbidities.
Okay, I want to stop right there and push back a little, or at least ask for a deeper translation, because when I look at a list like that, some of it is incredibly obvious.
Sure.
If you have a known history of drug allergies, of course you're at a higher risk. But there are two items on that list that require an explanation: female sex and elderly age.
I'm glad you caught that.
What is it about our fundamental baseline biology that changes how a pill works? Why are older people and women inherently more vulnerable to toxicity?
That is the perfect question, and answering it requires us to introduce a concept called pharmacokinetics.
Let's apply the explain like I'm five rule here. What is pharmacokinetics?
In the simplest terms, pharmacodynamics is what the drug does to the body. Pharmacokinetics is what the body does to the drug. Specifically, it's the journey of the chemical through four stages: absorption into the blood, distribution throughout the tissues, metabolism to break it down, and excretion to get it out. We call it ADME.
Absorption, distribution, metabolism, excretion, ADME. Okay.
Let's look at the elderly population first, specifically through the lens of metabolism and excretion. The primary organs responsible for these tasks are the liver, our chemical processing plant, and the kidneys, our filtration system.
Right.
As we age, these organs fundamentally change. Liver blood flow decreases, and the liver physically shrinks. The kidneys lose functional units called nephrons.
So the body's internal waste management infrastructure is basically just degrading.
Yes. So imagine a 30-year-old takes a standard dose of a medication. Their robust liver metabolizes the active chemical into inactive byproducts quickly, and their kidneys filter those byproducts into their urine. The drug does its job and leaves.
Very efficient.
Now give that exact same standard dose to an 85-year-old. Their liver can't process it as fast, their kidneys can't excrete it efficiently.
So the chemical just stays in the bloodstream.
It stays, and it circulates, and it accumulates. If they take another pill the next day, it stacks on top of the drug that never left.
Oh, wow. So it just builds and builds.
Exactly. What was a safe standard dose for a young adult becomes a massive toxic overdose for an elderly patient, simply because their body couldn't clear the room before the next guest arrived.
That makes total sense. It's a plumbing and filtration issue. But what about the female sex as a risk factor? A 30-year-old woman has perfectly fine liver and kidney function. Why is she at higher risk than a 30-year-old man?
It comes down to evolutionary biology and body composition. On average, female bodies possess a higher percentage of adipose tissue body fat compared to male bodies, which generally have a higher percentage of muscle mass and total body water.
And this impacts that distribution phase you mentioned.
Severely. Drugs are generally either water-soluble or fat-soluble. If you give a water-soluble drug to a woman because she has a lower volume of total body water, the drug is dissolved in a smaller pool of fluid. This means the concentration of the drug in her blood will be significantly higher than in a man taking the exact same dose.
Because it's less diluted.
Yes. Conversely, if it's a fat-soluble drug, it will distribute heavily into the adipose tissue and get trapped there, meaning it takes much, much longer for the drug to finally be released and cleared from her system.
So the standard dose is basically calculated for an average male body, and it completely ignores the fluid dynamics of a female body.
Historically, yes. Because for decades, clinical trials primarily used young male subjects to avoid the complexities of the menstrual cycle or potential pregnancy. We're just now grappling with the consequences of that.
That's incredible. And a little maddening.
Furthermore, women's livers express different levels of specific metabolizing enzymes known as the cytochrome P450 system, which are influenced by estrogen and progesterone. So women literally break down certain chemicals at entirely different speeds than men.
And if they're pregnant?
If a woman is pregnant, her blood volume expands by up to 50%, her kidney filtration rate skyrockets, and her liver metabolism completely shifts.
It really exposes the fallacy of the standard adult dose. There is no standard adult. Your biology dictates the reality of the chemical.
Precisely. And genetics plays a massive role too. Your DNA provides the blueprint for those liver enzymes. Some people are genetic ultra-rapid metabolizers who chew up a drug so fast it never helps them. Others are poor metabolizers who lack the enzyme entirely, so the drug immediately turns toxic.
So that's the patient side of the equation. We are a messy, variable target. Let's look at the drug-related factors, the weapons themselves. What makes a specific medication more likely to cause a crisis?
The clinical data outlines several key factors. The most prominent is polypharmacy.
Polypharmacy, meaning taking many drugs at once.
Yes. In geriatric care, it's incredibly common for a patient to be on, 5, 10, sometimes 15 different medications simultaneously. And this isn't just about taking a lot of pills. It's about the mathematical chaos of drug interactions.
Right, because if I take drug A and it has a 5% chance of a reaction and drug B has a 5% chance, taking them together isn't a 10% chance. It's a whole new chemical equation.
Exactly. Let's dive into the mechanism of why polypharmacy is so dangerous. Let's say drug A is highly bound to plasma proteins in your blood. It likes to hitch a ride on a protein called albumin.
Okay, albumin is the transport.
Right. Only the free, unbound portion of the drug floating in the blood actually causes a biological effect. Now, you introduce drug B. Drug B also wants to bind to albumin, and it has a stronger affinity for it.
Oh, I see where this is going. It's a game of molecular musical chairs.
That's exactly it. Drug B kicks drug A off the albumin proteins and into the free bloodstream.
Whoa.
The patient hasn't taken an extra pill, but suddenly the amount of active free drug A in their system just doubled or tripled. They're experiencing a massive, potentially fatal overdose, simply because a second drug bumped the first one off its transport protein.
That is terrifying. It's a silent overdose caused by traffic congestion in the blood.
And that's just one mechanism. The duration of therapy is another factor. The longer you take a chemical, the more time it has to accumulate or alter your cellular structures.
Okay, what else makes a drug dangerous?
Perhaps the most critical drug factor is something called a narrow therapeutic index.
A narrow therapeutic index. What does that actually mean?
Let's use an analogy. Imagine you are driving on a highway. The therapeutic index is the width of your lane. If you are taking an over-the-counter painkiller like ibuprofen, you are driving on a massive 10-lane empty highway.
Okay.
You can drift left, you can drift right, meaning you can take a little too much or a little too little, and you're generally going to be fine. The drug has a wide therapeutic index. The dose that helps you is very far away from the dose that hurts you.
Okay, wide lane, safe driving.
But a drug with a narrow therapeutic index is like driving an 18-wheeler on a tightrope across a canyon.
That sounds stressful.
It is. The mathematical difference between the minimum effective concentration, the dose required to actually treat your illness, and the minimum toxic concentration, the dose that causes severe organ damage, is razor thin.
So a tiny bit too little and your disease goes untreated, a tiny bit too much and the drug poisons you.
Yes. A classic example is a drug called lithium, used for bipolar disorder. The window of efficacy is so narrow that patients have to have their blood drawn constantly to ensure the drug hasn't tipped into neurotoxicity.
Oh, wow, just to make sure they're staying on the tightrope.
Or warfarin, a blood thinner. A millimeter too much, and the patient could suffer a spontaneous internal hemorrhage.
So combine all of this. You have an 82-year-old female patient. Her kidneys are slowing down. She has a high ratio of body fat. She is on 9 different medications competing for protein-binding sites. And one of those drugs is a blood thinner with a narrow therapeutic index.
It is a pharmacovigilance nightmare waiting to happen. And it happens in hospitals all over the world every single day.
Which brings us to the doctors on the front lines who have to manage this chaos. If you have a million different patients taking millions of combinations of drugs, producing thousands of different strange reactions, I mean, how do you even begin to categorize it? You need a filing system for the chaos.
You do. And pharmacologists use a very elegant, albeit dense, framework called the Rollins and Thompson classification. It categorizes every possible thing that can go wrong into a simple mnemonic time, the ABCs of adverse reactions. A, B, C, D, E, F.
Okay, let's walk through this alphabet of unintended consequences. We start with type A, stands for augmented.
Type A or augmented ADRs. These account for about 80% of all adverse drug reactions. They are by far the most common.
80%. Wow.
Yeah. The defining characteristic of a type A reaction is that it is a direct exaggeration of the drug's known intended pharmacological action.
So the drug isn't doing something weird or unexpected. It's doing exactly what you hired it to do. It's just doing it way, way too aggressively.
Exactly. And because we know exactly how the drug works, these reactions are highly predictable. They're also dose-dependent.
Meaning more drug equals a worse reaction.
Right. The more the drug you take, the more augmented and severe the reaction becomes. And crucially, while they happen very frequently, they rarely kill the patient. The mortality rate is low, and the treatment is usually very simple. Just reduce the dose.
The clinical notes provide some clear examples here, like a diabetic patient taking insulin. The intended pharmacological action of insulin is to lower blood sugar by pushing glucose out of the blood and into the cells.
Right. But if the effect is augmented, perhaps they took a little too much or they skipped a meal, the insulin pulls too much glucose out of the blood.
And the brain needs that glucose.
Desperately. The brain, which relies entirely on glucose for fuel, begins to starve. The patient experiences hypoglycemia, sweating, tremors, confusion, and potentially a coma. It's an augmented reaction.
Or warfarin. The intended action is to thin the blood to prevent clots in the heart. But if it's augmented, the blood becomes so thin that the patient starts experiencing spontaneous bruising or internal bleeding.
Exactly. The drug did its job too well. Now, to truly understand type A reactions, Dr. Manoj's work breaks them down into 6 specific subclassifications. Instead of just listing them, let's look at the mechanisms of how these augmented failures actually happen in the body.
I love that.
The first is a simple overdose.
This is exactly what we just talked about, right? The absolute volume of the drug is too high, or the kidneys failed to clear it, leading to toxicity, like the insulin example.
Yes. The second subtype is where things get interesting. Secondary effects. This is an indirect consequence of the drug's primary action.
Meaning?
The drug does exactly what it's supposed to do, but by doing so, it alters the biological environment and clears the way for a new secondary problem.
How does a drug alter the environment?
Think about broad-spectrum antibiotics. You have a severe sinus infection. You take a powerful antibiotic designed to carpet bomb bacteria.
Okay, sounds good so far.
The drug succeeds. It kills the bacteria in your sinuses. But that antibiotic doesn't differentiate between the bad bacteria in your head and the good symbiotic bacteria living in your gut or your mouth.
Oh, right. It wipes out the entire microbiome.
It does, and those good bacteria were occupying space and consuming resources, essentially acting as a defense force against other pathogens. When the antibiotic wipes them out, it creates a biological vacuum.
So something else moves in.
Suddenly, opportunistic fungi, like Candida, which are normally kept in check by the bacteria, realize the neighborhood is empty. They rapidly multiply. The patient is cured of the sinus infection but develops severe oral thrush or a dangerous intestinal C. difficile infection.
Wow. The drug worked, but the secondary effect was devastating.
The cure paved the way for the next disease.
Okay, the third subtype is the formal definition of a side effect.
Right. In this classification system, a side effect isn't just any unwanted thing. It is specifically an expected, unintended effect occurring at normal therapeutic doses because the drug is acting on normal physiological targets outside of the disease area.
This is our chlorpheniramine, the allergy pill, causing drowsiness.
Exactly. We wanted it to block histamine in the nose to stop the sneezing, but it also blocked histamine in the brain, causing sleep. It hit the right receptor, just in the wrong organ.
That brings us to the fourth, type A mechanism drug interactions. We touched on this with the albumin transport proteins earlier, but the clinical data gives a very specific, dangerous example involving our blood thinner, warfarin.
Yes. Imagine a patient stabilized on warfarin. Their blood is perfectly thinned. Then they get an infection, and a different doctor prescribes an antibiotic called metronidazole. Here is the biological drama.
I'm ready.
Warfarin is metabolized or broken down by a specific set of enzymes in the liver. Metronidazole is a chemical inhibitor of those exact same enzymes.
Let me guess. The antibiotic shuts down the liver's ability to process the blood thinner.
Completely. The antibiotic acts like a roadblock in the liver. The warfarin hits the roadblock, cannot be broken down, and bounces back into the bloodstream.
That sounds really bad.
The warfarin levels rapidly skyrocket, the blood loses all ability to clot, and the patient is at imminent risk of a catastrophic hemorrhage. This is a classic, predictable, augmented pharmacokinetic drug interaction.
The fifth subtype is toxic effects, which is direct tissue damage from accumulation, which we will dive deeply into later when we talk about antidotes. So let's look at the final, and to me, the most fascinating type A subclassification, pharmacogenetic effects.
This is where we cross into the realm of DNA. A pharmacogenetic effect is an augmented reaction driven entirely by a patient's unique genetic code. It proves that a drug can be perfectly safe for 99% of the population and a deadly poison to 1%.
The clinical example given here is a drug called Primaquine, which is an anti-malarial drug, and it causes something called hemolysis in patients with a specific genetic deficiency. Walk us through the molecular biology of this, because it sounds intense.
It is a brilliant example of genetic vulnerability. Inside every human red blood cell, there's an enzyme called G6PD.
G6PD.
You can think of G6PD as a biological shield. Its entire job is to protect the red blood cell from oxidative stress. Basically, it neutralizes harmful free radicals that would otherwise tear the cell membrane apart.
Okay, so G6PD is the shield protecting the blood cells.
Yes. Now, Primaquine, the antimalarial drug, is a chemical that induces a massive amount of oxidative stress. In a genetically typical person, they take Primaquine, the oxidative stress spikes. But the G6PD shields activate, neutralize the threat, and the red blood cells are perfectly fine. The drug goes on to kill the malaria parasite.
But what if you have the genetic deficiency?
Millions of people, particularly of African and Mediterranean descent, have a genetic mutation where they produce very little or defective G6PD, no shields. If a doctor, unaware of this genetics, prescribes Primaquine, the drug enters the blood and unleashes oxidative free radicals. Without the G6PD shield to protect them, the red blood cell membranes are literally ripped apart. They burst open in the bloodstream.
That's the hemolysis, the destruction of the blood.
Yes, the patient suffers acute, massive hemolytic anemia simply because their DNA lacked the instructions to build a shield against that specific chemical. It's a predictable, augmented reaction, but only if you know the patient's genetic code.
That is incredible and terrifying. Okay, so that summarizes type A, augmented, dose-dependent, predictable reactions ranging from overdoses to genetic mismatches.
Right.
Let's move to the second letter of the alphabet. Type B stands for bizarre, and if type A is the predictable logical category, type B sounds like the Wild West.
It is the terrifying Wild West of pharmacology. Type B, bizarre ADRs, are the exact opposite of type A. They are completely unpredictable based on the drug's known pharmacology. They are relatively rare. And most crucially, they are dose-independent.
Dose-independent, meaning you don't need an overdose to trigger it.
Exactly. You could give a patient a microscopic fraction of a normal dose, a crumb of a pill, a single drop of an IV, and it can trigger a massive, explosive, life-threatening reaction. The severity has nothing to do with the volume of the chemical.
Wow.
And the clinical framework draws a very hard, very important line dividing type B reactions into two distinct biological mechanisms: idiosyncrasy and allergy.
Let's untangle those, because I hear people say, oh, I have a weird idiosyncrasy to that drug, or I'm allergic to it, and they mean the exact same thing.
Yeah.
But biologically, they are fundamentally different, right?
They are completely different biological wars being fought in the body.
Yeah.
Let's start with idiosyncrasy. An idiosyncratic reaction is an abnormal, highly unusual response to a drug that is genetically determined. But here is the critical distinction. It does not involve the immune system.
No antibodies, no white blood cells attacking the drug.
Correct. It is usually a bizarre metabolic failure. The patient's body processes the chemical in a totally aberrant way, creating toxic byproducts that damage organs directly.
What's a good example of that?
The classic example in medical literature is halothane, an inhaled general anesthetic used in surgery. In a tiny fraction of patients, due to an unknown genetic quirk, their liver metabolizes halothane into a highly reactive, toxic compound.
So the liver basically poisons itself while trying to break down the gas.
Exactly. It causes severe acute idiosyncratic hepatitis, massive liver inflammation, and necrosis. It's bizarre, it's unpredictable, but it is a metabolic failure, not an immune attack.
Okay, so if idiosyncrasy is a metabolic error, allergy must be the immune system going rogue.
Yes, a drug allergy is entirely immune-mediated. It is a case of mistaken identity. The body's immune system detects the drug molecule, incorrectly identifies it as a hostile, deadly pathogen like a virus or a parasite, and launches a full-scale systemic military assault to destroy it.
The clinical notes provide a step-by-step biological breakdown of the pathogenesis of hypersensitivity. I want to spend some time here because everyone knows what an allergic reaction looks like on the outside. Hives, swelling, anaphylaxis. But what is actually happening on a cellular level? Walk us through the immune cascade.
It is a highly coordinated, terrifyingly fast biological mechanism. Let's look at the classic type 1 IgE-mediated hypersensitivity. There's a multi-step chain reaction. Step 1 is exposure. The patient takes the drug, let's say penicillin, for the very first time.
Does the patient get sick on this first exposure?
Usually, no. Outwardly, nothing happens. The penicillin cures their infection. But microscopically, step 2 is occurring. Sensitization.
Sensitization.
As the penicillin circulates, the immune system's reconnaissance units called antigen-presenting cells, or APCs, detect the penicillin molecules. They swallow them, break them down, and present fragments of the drug to the immune system's generals, the T helper cells.
The scouts are showing the generals a piece of the enemy.
Exactly. The T helper cell looks at the penicillin fragment, erroneously decides it is a massive threat, and sends chemical distress signals to the weapons factories, the B cells.
Okay, the B cell.
The B cells receive the signal and begin mass-producing a very specific type of weapon called IgE antibodies. These antibodies are perfectly chemically tailored to lock onto penicillin and nothing else.
So the immune system has essentially printed millions of biological wanted posters specifically for penicillin.
Yes. Now we enter step 3, binding. These millions of IgE antibodies travel through the bloodstream and embed themselves into the surface of mast cells and basophils.
What is a mast cell? ELI5, that for me.
Think of a mast cell as a biological landmine. They are immune cells stationed heavily in tissues that interface with the outside world, your skin, your lungs, your gastrointestinal tract, your blood vessels. Inside these mast cells are thousands of tiny granules packed with incredibly powerful, violent inflammatory chemicals, primarily histamine.
Okay, so we have landmines packed with histamine sitting in the lungs and skin.
And now, thanks to the sensitization phase, those landmines are coated with IgE antibodies, the wanted posters for penicillin. The trap is set. The patient recovers from their infection and goes about their life, completely unaware that their body is now a heavily mined zone specifically targeting penicillin.
Which brings us to step 4, re-exposure.
Years later, the patient gets another infection. The doctor prescribes penicillin. The patient swallows the pill. The drug absorbs into the blood and circulates. Within minutes, the penicillin molecules bump into the mast cells. They perfectly match the IgE wanted posters.
Oh man, the trap is sprung.
The drug molecule binds to two adjacent IgE antibodies on the surface of the cell, pulling them together. This is called cross-linking.
And cross-linking is the trigger that trips the landmine.
It pulls the pin on the grenade.
Marking-
Step 5 is degranulation. The mast cell instantly ruptures, violently dumping its entire payload of histamine, leukotrienes, and prostaglandins into the surrounding tissue.
And step 6 is the clinical manifestation, the explosion.
Exactly. All that histamine causes blood vessels to rapidly dilate and leak fluid. If this happens in the skin, you get massive, raised, itchy hives, urticaria. If it happens in the lungs, the smooth muscle violently contracts, closing the airways and causing sudden severe asthma. And if it happens systemically, throughout the entire bloodstream.
That's anaphylaxis.
Yes. All the blood vessels in the body dilate at once. The patient's blood pressure plummets to near zero. They go into shock. Their throat swells shut. And without immediate intervention, they will die.
Yeah.
All because a scout cell made a mistaken identification years prior.
It is astonishing that a microscopic chain reaction can bring a fully grown human to the brink of death in under 10 minutes, independent of the dose. That truly earns the bizarre classification.
It definitely does.
All right, we've covered A and B. We need to complete the Rollins and Thompson alphabet. Let's move through C, D, E, and FC. It stands for chronic.
Type C ADRs are simple. They're related entirely to the long-term chronic use of a drug. It's not a single toxic dose, and it's not a bizarre allergy. It's the slow, cumulative wear and tear of a chemical on a biological system over months or years.
Like what?
For example, long-term use of certain painkillers destroying kidney function over a decade.
Okay, slow and steady damage. Type D stands for delayed.
Type D reactions are insidious. These are severe adverse effects that only appear long after the treatment has been completely stopped, sometimes years or decades later. The clinical history provides two incredibly heavy examples here. The first is teratogenicity drugs causing severe birth defects.
The thalidomide tragedy.
Yes. In the late 1950s, thalidomide was aggressively marketed as a safe, mild sedative and a cure for morning sickness in pregnant women. Women took it, felt fine, and stopped taking it. But the drug was profoundly teratogenic.
How so?
It inhibited angiogenesis, the formation of new blood vessels in the developing embryo. Months after the mothers stopped taking the drug, thousands of babies were born with phocomelia, which is the severe malformation or absence of limbs. It was a delayed reaction that changed modern drug regulation forever.
A dark, defining moment in medicine. What is the other example of a delayed reaction?
Secondary malignancies caused by chemotherapy. A patient undergoes intense toxic chemotherapy and successfully beats a primary cancer, like lymphoma. They are declared cancer-free.
Yeah, that's great news.
But those chemotherapy drugs work by shredding DNA to kill a cancer. In the process, they can cause subtle, delayed DNA mutations in healthy cells. 10 or 15 years later, the patient develops a completely new treatment-resistant leukemia purely as a delayed consequence of the drug that saved their life a decade prior.
The ultimate double-edged sword.
Okay.
Type E stands for end of use.
These are withdrawal or rebound effects that occur after the abrupt discontinuation of a drug. If you artificially alter a biological system for long enough, the body adapts. It creates a new baseline. If you violently kick away that chemical crutch, the system crashes.
The clinical notes mention adrenal crisis from stopping corticosteroids. Walk us through that mechanism.
Your adrenal glands naturally produce cortisol, a crucial steroid hormone that manages stress, blood pressure, and inflammation. If a patient is prescribed high-dose synthetic corticosteroids like prednisone for months to treat an autoimmune disease, the brain senses the massive amount of steroids in the blood.
And what does it do?
It tells the adrenal glands, hey, we have plenty of steroids. You guys can shut down and go to sleep.
The body stops manufacturing its own supply.
Exactly. The adrenal glands atrophy and go dormant. Now, if the patient suddenly stops taking the prednisone pills cold turkey, the exogenous supply is gone. But the adrenal glands are still asleep. They can't wake up instantly.
So there's just no cortisol at all.
Suddenly, the patient has zero cortisol in their body. They go into an acute adrenal crisis, profound weakness, severe vomiting, dangerously low blood pressure, and potentially cardiovascular collapse.
Which is exactly why every doctor relentlessly repeats, do not stop taking this medication without tapering off. They basically have to slowly wake the adrenal glands back up.
Yes, a slow taper is essential.
Finally, we reach type F. F stands for failure.
Type F ADRs are when the drug completely, unexpectedly fails to produce its intended therapeutic effect.
I have to ask, how is a drug just not working considered an adverse reaction that's not doing anything noxious?
Because in medicine, failure to treat a lethal disease is just as noxious as a poison. If you have a severe bacterial pneumonia and the antibiotic fails to work, you die. The failure is the adverse outcome.
I see. That makes sense.
The notes highlight two specific mechanisms for failure. The first is antimicrobial resistance, where the bacteria have genetically evolved to destroy the antibiotic. But the second mechanism is far more interesting from a pharmacological perspective. It involves drug interactions causing failure.
Tell me more.
The specific clinical example given is a woman experiencing an unintended pregnancy while strictly taking oral contraceptives.
How does a birth control pill fail if she takes it perfectly?
Because of what else she is taking. Let's say she is also prescribed a drug called rifampicin, which is a powerful antibiotic used for tuberculosis. Rifampicin is what we call an enzyme inducer. When it hits the liver, it acts like a tyrannical factory manager. It forces the liver to rapidly build millions of new cytochrome P450 metabolizing enzymes.
It ramps up the liver's processing power.
Massively. Now, the woman takes her daily oral contraceptive pill, which it contains estrogen. The estrogen enters the liver, expecting the normal, slow rate of metabolism. But instead, it is met by a massive, hyperactive army of enzymes induced by the rifampicin.
So they just destroy the estrogen.
The liver absolutely chews up and destroys the estrogen before it can ever reach the bloodstream to stop ovulation. The birth control pill is destroyed before it can work. The result is a type F reaction therapeutic failure and an unintended pregnancy, driven entirely by a liver enzyme interaction.
That is just phenomenal biology. The liver was moving so fast it shredded the hormones.
Okay, I want to pivot here and circle back to something we touched on in the type A augmented category, toxic effects.
Yeah.
We talk about how the dose makes the poison.
Yes.
The clinical framework has a whole section dedicated to toxicity and how emergency rooms manage it. First, it defines absolute toxicity versus relative toxicity. What is the difference?
It comes back to the concept of vulnerability. Absolute toxicity is purely a matter of sheer volume and chemistry. It occurs when a dose heavily exceeds the maximum tolerated dose for the entire human population.
So it doesn't matter who you are. Right. It doesn't matter if you are young, old, genetically gifted, or impaired. If you take a massive, intentional overdose of paracetamol Tylenol, it will overwhelm your liver pathways and cause massive cellular necrosis. That is absolute toxicity.
A lethal dose for anyone. And relative toxicity.
Relative toxicity occurs at normal, usual therapeutic doses. The volume of the drug is completely standard, but it causes severe life-threatening toxicity in a susceptible individual because of the risk factors we discussed earlier: age, kidney failure, or genetic lack of enzymes.
The dose is standard, but the patient's capacity to handle it is compromised.
Exactly. The clinical example provided is giving a standard dose of the antibiotic chloramphenicol to neonates' premature newborns. For a 5-year-old child, the dose cures the infection. But a newborn's liver is chemically immature. It literally hasn't learned how to build the enzyme required to bind and excrete chloramphenicol.
So it just builds up.
It accumulates exponentially, causing a fatal cardiovascular collapse known as gray baby syndrome. A normal dose for one is a toxic dose for another.
So, whether a patient comes into the ER with an absolute intentional overdose or a relative accidental toxicity, they're in a critical medical emergency. The clinical data provides a clear management flowchart. Walk us through the ER protocol. What is the playbook for reversing a poisoning?
It is a rigid, prioritized, algorithmic approach. Step 1, recognize toxicity. The clinical team has to quickly identify toxidromes, patterns of symptoms like pinpoint pupils, severe sweating, specific heart arrhythmias, and link them to a chemical exposure.
Makes sense.
Step 2, stop the offending drug, stop the eye, pump the stomach, isolate the patient from the poison.
Step 3, assess and support.
Yes. Before you even try to neutralize the poison, you have to keep the biological machine running. You intubate the airway if they can't breathe. You push IV fluids to stabilize crashing blood pressure. You restart the heart if it stops. You support vital functions.
Then step 4, remove or reduce the unabsorbed drug.
Try to get the chemical out before the body absorbs it. This involves gastric lavage, physically washing out the stomach, or administering activated charcoal, which acts like a massive chemical sponge in the intestines, binding to the drug so it gets pooped out rather than absorbed into the blood.
And then we arrive at step 5, which is honestly my favorite part of this entire deep dive. Administer antidote, if available.
Yes, antidotes are the pinnacle of pharmacological engineering. They are specific, molecular lock-and-key mechanisms designed to intercept, neutralize, or reverse a specific chemical poison.
Let's geek out over this antidote arsenal for a second, because the clinical notes list 8 specific poisons and their chemical antidotes, but I don't just want the names, I want the molecular drama.
Let's do it.
I'm going to list the poison, and I want you to tell me the antidote and how it saves the patient's life. Are you ready?
I am ready.
Number 1, paracetamol or Tylenol. An overdose causes severe hepatotoxicity, destroying the liver.
The antidote is N-acetylcysteine, commonly called NAC. Here is the mechanism. When you overdose on Tylenol, your liver runs out of its normal processing pathways and starts turning the drug into a highly toxic, highly reactive compound called NAPQI. NAPQI violently binds to liver cells and kills them.
Okay, so NAPQI is the bad guy.
Yes. Normally, your body uses a molecule called glutathione to neutralize NAPQI, but in an overdose, you run out of glutathione. NAC, the antidote, is basically a massive delivery of raw materials. It floods the liver, forcing it to rapidly manufacture new glutathione, which then neutralizes the toxic NAPQI and stops the liver from dying.
It's sending emergency supplies to the factory to build more shields. Awesome. Number 2, opioids like morphine, fentanyl, or heroin causing life-threatening respiratory depression. The patient stops breathing.
The antidote is naloxone. Opioids work by plugging into specific neuroreceptors in the brainstem, which dulls pain but also shuts down the brain's drive to breathe. Naloxone is a competitive antagonist. Its molecular shape allows it to perfectly fit into that exact same receptor, but it has a much stronger affinity than the opioid.
Like it pushes it out.
Exactly. It acts like a biological battering ram, physically kicking the opioid molecules out of the receptors, but without activating the receptor itself. Within seconds, the brain wakes up and the patient gasps for air.
It kicks the key out of the lock. Number 3, benzodiazepines like Valium or Xanax causing severe central nervous system depression.
The antidote is flumazenol. Benzodiazepines work by enhancing a neurotransmitter called GABA, which acts as the brain's brake pedal, slowing everything down. Flumazenol goes into the brain and specifically blocks the benzodiazepine binding site on the GABA receptor. It rips the drug's foot off the brake pedal, allowing the brain to accelerate back to normal consciousness.
Wow. Number 4, organophosphates, which are highly toxic chemicals often found in agricultural pesticides, causing a massive cholinergic crisis, severe muscle spasms, uncontrollable salivation, and respiratory failure.
This is a complex poisoning that requires a 2-part tag team antidote. Atropine plus pralidoxime, often called 2PM. Organophosphates work by attacking and permanently disabling an enzyme called acetylcholinesterase. Without this enzyme, a neurotransmitter called acetylcholine rapidly builds up in the body, putting every muscle and gland into massive, fatal overdrive.
So how do the 2 drugs work together?
Atropine acts first as a shield. It blocks the receptors from receiving the massive flood of acetylcholine, stopping the spasms. Then pralidoxime acts as the extractor. It chemically pries the organophosphate poison off the enzyme, reactivating the enzyme so it can clean up the mess.
That is James Bond level chemistry right there. A shield and an extractor. Number 5, warfarin, the blood thinner, causing catastrophic bleeding.
The antidote is vitamin K, also known as phytonadione. Warfarin works entirely by blocking the liver's ability to use vitamin K to build clotting factors. If you are bleeding out, we give you a massive, overwhelming intravenous dose of active vitamin K, bypassing the warfarin blockade and allowing the liver to frantically rebuild the blood clots.
Number 6, heparin, a different type of blood thinner also causing severe bleeding.
For heparin, we use protamine sulfate. This is a brilliant example of acid-base neutralization. Heparin is a heavily negatively charged acidic molecule. Protamine sulfate is a heavily positively charged alkaline protein derived, interestingly enough, from salmon sperm.
Wait, salmon sperm?
Yes. When you inject the protamine, the positive and negative molecules instantly crash into each other in the blood, bind together, and form an inert, harmless salt complex. The heparin is neutralized instantly.
They literally cancel each other's electrical charge out. Incredible. Number 7, digoxin, a heart medication that in toxicity causes lethal cardiac arrhythmias.
The antidote is digoxin-specific Fab fragments, or digoxin immune Fab. Digoxin poisons the heart by disabling a crucial cellular pump, the sodium-potassium ATPase pump. The Fab fragments are literally synthetic antibodies. We inject them into the blood, and they act like millions of molecular sponges.
Sponges for the drug.
Yes. They hunt down the free digoxin molecules, bind tightly to them, and trap them so they can't touch the heart. The kidneys then filter the whole complex out into the urine.
And finally, number 8, severe iron poisoning, often seen in children who eat adult vitamin pills.
The antidote is deferoxamine. Iron is a heavy metal. In massive doses, free iron in the blood acts like a wrecking ball, generating highly destructive free radicals that shred cellular structures and cause cardiovascular collapse.
And what does deferoxamine do?
Deferoxamine is a chelating agent. The word chelation comes from the Greek word for claw. The deferoxamine molecule literally wraps its chemical claws around the free iron atoms, trapping them in a water-soluble cage. The body can then safely pee out the caged iron. It turns the urine a distinct, dark reddish-brown color, which means the antidote is working.
That is just incredible. For all of these terrifying metabolic crises, there is a literal specific chemical key engineered to turn off the damage.
It is miraculous. But notice the flowchart says, administer antidote if available. The harsh reality is that for the vast majority of pharmaceutical drugs, there is no neat and tidy chemical antidote.
Really?
Yeah, if you overdose on most blood pressure meds or antidepressants, there is no magic lock and key, which is exactly why steps 1 through 4, recognize, stop, support vital functions, and flush the system, are so universally critical. The emergency room has to keep you alive long enough for your own liver and kidneys to do the hard work.
Speaking of things that are difficult to manage, the clinical data pivots here to highlight a very visible, highly specific, and kind of mind-bending way that drugs can cause harm. We've talked about drugs destroying the liver, stopping the heart, altering the brain, but this section details how drugs interact with our external environment, specifically sunlight.
Yes, photosensitivity.
Yeah.
It is one of the most fascinating and misunderstood areas of adverse drug reactions.
Because we usually think of a chemical reacting with our internal organs, but this is a pill you swallowed reacting with the star 93 million miles away. How does taking an antibiotic make you allergic to the sun?
It's a cutaneous, a skin-level reaction resulting from drug-induced sensitization to ultraviolet radiation. And just like we saw with the type B bizarre reactions earlier, the clinical framework clearly divides photosensitivity into 2 entirely distinct biological mechanisms: phototoxic reactions and photoallergic reactions.
Let's break those down. What is a phototoxic reaction?
A phototoxic reaction is non-immunologic. The immune system is not involved at all. It can occur in literally any human being if they have enough of the drug in their system.
How does it work?
Here's the mechanism. You take the pill, the drug absorbs into your blood and eventually distributes into the outer layers of your skin. When you walk outside, UV photons from the sun penetrate your skin and physically strike those specific drug molecules.
The light hits the chemical inside the skin.
Exactly. The drug molecule absorbs the energy of the photon and becomes highly unstable and excited. To return to a stable state, the drug molecule violently releases that excess energy into the surrounding tissue, often in the form of destructive free radicals and reactive oxygen species.
So the drug is acting like a magnifying glass for the sun's radiation. It's absorbing the light and using it to burn the skin cells from the inside out.
That is exactly what happens. It causes direct, catastrophic cell membrane damage. Clinically, it looks like a severe, incredibly fast onset sunburn. We're talking intense erythema, redness, edema, or swelling, and painful vesicular eruptions or blistering. It happens within minutes or hours of sun exposure, and as it heals, it leaves behind severe hyperpigmentation, darkening of the skin, and desquamation, which is peeling.
What kind of common drugs turn your skin into a solar oven?
The major culprits for acute phototoxicity are tetracycline antibiotics, commonly used for acne, and tar products used in dermatological ointments. Chronic, lower-grade sensitizers include fluoroquinolone antibiotics, certain NSAIDs, and thiazide diuretics used for blood pressure.
Okay, so if that's phototoxic, direct chemical burning, what is a photoallergic reaction? I assume the immune system has entered the chat.
You assume correctly. Photoallergic reactions are entirely immunologic. They are a delayed hypersensitivity response, and they only occur in a small percentage of sensitized individuals. The mechanism is a bizarre twist on the allergy cascade we discussed earlier.
Walk me through the twist.
The patient takes the drug, and it distributes into the skin. But the drug itself isn't an allergen. The immune system ignores it. However, when the patient steps into the sun, a very specific wavelength of light UVA radiation hits the drug molecule. The energy from the UVA photon physically alters the chemical structure of the drug. It changes its shape.
The sun modifies the
Right,
drug.
yes. The drug is converted into a new foreign molecule. Suddenly, the immune system looks at this new shape and says, that is an invader. Antigen-presenting cells, grab it, present it to T cells, and a massive cell-mediated immune attack is launched against the skin where the modified drug resides.
So the immune system is primed, but it takes the UVA light to actually pull the trigger and reveal the target.
Precisely. And because it's a T-cell immune response, it takes 24 to 48 hours to develop, and it does not look like a sunburn. It looks like severe weeping eczema or contact dermatitis raised incredibly itchy, scaly lesions.
Yeah, that sounds miserable.
And the worst part, unlike the phototoxic sunburn that fades when you get out of the sun, a photoallergic reaction can persist for weeks or months even after the drug is stopped. Sometimes the immune system becomes so confused it causes persistent light reactivity, where the patient breaks out in hives just from walking to their mailbox, even without the drug.
Are there common drugs for this one too?
The major culprits here are sulfonamide antibiotics, sulfonylureas used for diabetes, and the anti-malarial chloroquine.
It really emphasizes that when a pharmacist hands you a bottle with a yellow sticker that says, avoid direct sunlight, they aren't suggesting you wear a hat. They are warning you about a massive biochemical reaction.
Ignore those warning labels at your own peril.
Now, there is one more heavy, somewhat dark term brought up in this clinical framework before we get into the global tracking system. The term is iatrogenic disease.
Yes. Iatrogenic.
Mm-hmm.
The root of the word comes from Greek iatros, meaning physician, and genic, meaning produced by, it literally translates to physician-induced disease.
That is a brutal phrase, physician-induced disease. It sounds like an accusation.
It is a harsh reality of medical practice, and it's a necessary categorization for severe adverse outcomes. An iatrogenic disease refers to a new pathology, a new chronic condition that is directly caused by a medical intervention or drug.
Okay.
But the defining, terrifying characteristic of an iatrogenic illness is that the disease state persists and continues to damage the patient long after the offending drug has been completely withdrawn.
So the damage becomes self-sustaining. The drug lights the fire, but the house keeps burning even after you take away the match.
Exactly. The clinical framework provides a perfect, common example. Peptic ulcer disease caused by chronic use of NSAIDs, like high-dose ibuprofen or naproxen. NSAIDs relieve pain by blocking an enzyme called CyoX1. But CyoX1's primary job in the stomach is to produce a thick, protective layer of mucus that stops the stomach's own acid from digesting the stomach wall.
So the painkiller turns off the stomach's natural defense shield.
Yes. The patient takes the NSAIDs for a bad back for a year. The protective mucus disappears. The highly corrosive stomach acid burns a deep bleeding hole and ulcer into the stomach lining. Now, the patient stops taking the NSAID, the drug is completely out of their system, but that gaping, bleeding ulcer is still there.
Right. The hole doesn't just vanish.
It is a persistent, independent disease state that now requires entirely separate medical intervention, surgeries, and proton pump inhibitors to heal. The physician's attempt to cure the back pain induced a severe gastrointestinal disease. Another example is severe irreversible liver cirrhosis caused by the prolonged use of the tuberculosis drug ithoniazid. The drug kills the liver tissue to a point where the scarring becomes permanent.
Okay. We have covered a truly massive, frankly terrifying amount of possibilities here. We've untangled AEs, ADRs, and ADEs. We've looked at how failing kidneys and genetic mutations turn standard doses into lethal poisons. We've walked through the A through F alphabet of reactions, from predictable insulin crashes to bizarre immune-mediated anaphylactic explosions.
It's letter biology.
We've looked at molecular antidotes, sun-induced blistering, and permanent physician-induced diseases. With all of these variables, with 8 billion people on Earth taking tens of billions of pills every single day, how on earth does the medical world keep track of it all? Because looking at all this biology, it sounds like it should be absolute, unmitigated chaos.
It would be chaos. And historically, it was chaos, if not for the global detective agency known as Pharmacovigilance.
Pharmacovigilance, it sounds like a government intelligence agency in a spy movie.
It functions very much like an intelligence agency, just for molecular safety. The formal definition, as outlined in Dr. Manoj's clinical presentation, is that pharmacovigilance is the science and activities relating to the detection, assessment, understanding, and prevention of adverse effects or any other drug-related problem.
And in plain English,
In plain English, it is the continuous, rigorous safety monitoring of medicines from the moment they are invented until the moment they are removed from the market.
What is this network actually trying to achieve every day? What are their core objectives?
The objectives are clear and systematic. First, detect adverse drug reactions as early as possible, especially new, rare, or bizarre ones that weren't caught in clinical trials. Second, assess the risks versus the benefits associated with every medicine. Third, understand the clinical causality, meaning did the drug actually cause the problem, or was it a coincidence? And fourth, prevent harm, improve patient safety, and promote the rational, safe use of medicines through regulatory action.
How do they actually detect these things out in the real world? Are scientists just sitting by a phone waiting for doctors to call them?
That brings up the critical difference between the two main methods of data collection: passive surveillance and active surveillance.
Let's contrast those. Passive surveillance first.
Passive surveillance is the most common method worldwide. It relies entirely on spontaneous voluntary reporting. A patient at a local clinic experiences a weird rash after taking a new blood pressure pill. They tell their doctor. The doctor recognizes it might be the pill, goes to their computer, and voluntarily fills out an adverse drug reaction reporting form.
Seems straightforward.
It is simple, it covers the entire population, and it is very low cost.
But if it's purely voluntary, it must have a massive flaw.
It has a fatal flaw: catastrophic underreporting. Think about the reality of a modern hospital. An ER doctor is managing trauma, heart attacks, and chaotic wards. If a patient has a mild reaction to an antibiotic, is that exhausted doctor really going to take 20 minutes to sit down and fill out a bureaucratic form?
Probably not.
Usually, no. The drug is stopped, the patient recovers, and the data point is lost forever. Studies suggest that up to 90% of all adverse drug reactions are never reported in passive systems.
So the database is missing most of the puzzle pieces. What is the alternative? Active surveillance.
Active surveillance is aggressive and rigorous. This is where hospitals, researchers, or regulatory bodies actively hunt for adverse drug reactions. They use computer algorithms to comb through millions of electronic health records looking for patterns like a sudden spike in liver failure codes among patients prescribed a newly approved drug.
That sounds much more effective.
They conduct systematic follow-ups, calling patients every week to document every symptom. It requires massive funding, dedicated staff, and high-tech infrastructure, but it is vastly more accurate and actually establishes true incidence rates of toxicity.
Okay, let's say a doctor does the right thing and fills out a spontaneous report for a patient. Let's trace the chain of custody for a single adverse drug reaction report. Where does it go?
The clinical framework outlines a very clear data pipeline, specifically highlighting the system in India, the Pharmacovigilance Program of India, or PVPI, which is a great model for how this scales globally. It starts at the ground level. The patient experiences an ADR. A doctor, pharmacist, or nurse recognizes it and fills out the standardized form.
Where does the physical or digital form go from the clinic?
It is submitted to the local AMC, an Adverse Drug Reaction Monitoring Center. These are usually established within major medical colleges or large regional hospitals. The pharmacologists, the AMC, review the raw data, verify the clinical details, ensure it's not a duplicate, and then they push it up to the national level NCC, or National Coordinating Center. In India, this is located at the Indian Pharmacopoeia Commission in Ghaziabad.
So now the national government has the data. Do they pass it to the regulators who make the laws?
Yes. The NCC analyzes trends across the entire country and shares that intelligence with the CDSCO, the Central Drug Standard Control Organization. That is the National Regulatory Authority, equivalent to the FDA in the United States. They're the ones with the legal power to actually change drug labels or pull a dangerous drug off the market.
But the data doesn't stop at the national border, does it?
No, and this is where the system becomes truly awe-inspiring. From the National Regulatory Authority in India, or the FDA in America, or the MHRA in the UK, that single patient's report is digitized and transmitted to the UMC, the Uppsala Monitoring Center, located in Sweden. The UMC maintains Vigibase, which is the World Health Organization's global database of individual case safety reports.
So literally, a woman gets a bizarre skin rash in a tiny rural clinic, her doctor files a report, and a few weeks later, that exact clinical event is a data point in a massive supercomputer in Sweden, being cross-referenced against millions of other drug reactions from Tokyo, London, and New York.
Exactly. It's an unprecedented level of global real-time data sharing. It's designed to detect faint safety signals, a rare one-in-a-million side effect that a single hospital or even a single country might never notice, but when aggregated globally, suddenly reveals a deadly pattern.
But here is the multi-million-dollar question for these clinical detectives. How do they actually prove a drug caused the issue? Because people get sick all the time. If I take a new pill on Tuesday and I break out in hives on Wednesday, it might be the pill, but it might be the new laundry detergent I bought. It might be a strange virus. It might be food poisoning.
Right.
It's easy to spot a reaction. It's incredibly difficult to prove guilt. How does the Pharmacovigilance Network establish causality?
You've hit on the core scientific challenge of the entire field. Causality assessment is the rigorous, systematic evaluation of the likelihood that a particular drug actually caused a suspected adverse event. And the first, most powerful clinical tools in a doctor's toolkit for establishing this are D-challenge and re-challenge.
De-challenge and re-challenge. Explain how those work in a clinical setting.
D-challenge is exactly what it sounds like. It is the immediate withdrawal of the suspected offending drug, followed by careful observation of the patient to see if the adverse reaction improves or resolves.
Basically, you turn off the chemical tap and see if the sink stops overflowing.
Precisely. It is safe, it is logical, and it is almost always the first step when an ADR is suspected, unless stopping the drug is immediately life-threatening to the patient's underlying condition, like stopping a pacemaker drug. If a patient has a severe rash, you stop the suspected antibiotic. If the rash completely disappears over the next 2 days, you have a positive D-challenge. It is a massive clue pointing to the drug's guilt.
And re-challenge.
Re-challenge is the deliberate readministration of the suspected drug after the adverse reaction is fully resolved, specifically to see if the toxic reaction reappears.
Wait, you're telling me a doctor will intentionally give a patient the exact chemical that just put them in the hospital? That sounds incredibly reckless. You're intentionally trying to make them sick again just to prove a point.
It sounds reckless, and in many cases it would be, which is why the clinical guidelines are exceptionally strict. Re-challenge carries immense risk and should only be done with extreme caution under intense medical supervision.
So they don't do it often.
No. It is only performed when it is absolutely essential to confirm causality, perhaps during a phase 3 clinical trial where billion-dollar decisions are being made, and only when the potential benefits of knowing for sure definitively outweigh the risks to the patient. It is absolutely not routine practice, and it is never, ever done in severe immune-mediated or life-threatening ADRs like anaphylactic shock, Stevens-Johnson syndrome, or massive liver failure.
Right. You don't test if someone is truly allergic to a live hand grenade by pulling the pin a second time.
Exactly. The risk of a type B immune explosion on a second exposure is too high. So because doctors rarely use re-challenge, they have to rely on standardized mathematical algorithms to weigh the clinical evidence and determine causality objectively.
The scales of justice for pharmaceutical guilt. The clinical framework lists several of these causality assessment algorithms.
Yes, and it provides a handy mnemonic to remember the major ones used globally, WNKKJ.
WNKKJ. Let's list the detectives.
W is for the WHO-UMC Causality Assessment Scale. N is the Naranjo algorithm, also known as the Naranjo probability scale. K is the Karchin-Lasagna scale. The second K is the Kramer algorithm. And J is the Jones algorithm.
The presentation heavily focuses on the Naranjo scale, which is arguably the most famous. It's essentially a rigorous interrogation questionnaire that gives you a numerical score. Walk us through how a doctor uses this to interrogate a case.
The Naranjo algorithm asks 10 very specific objective questions about the clinical event. It looks for timelines, alternative suspects, and objective proof. For example, question 1. Are there previous conclusive reports on this reaction? Does the medical literature already know this drug can do this?
Got it.
Question 2. Did the adverse event appear after the suspected drug was administered? Establishing the timeline. Question 3. Did the adverse reaction improve when the drug was discontinued? That's asking for the results of the D-challenge.
And crucially, it asks about alternative suspects, right?
Yes. Question 5 is critical. Are there alternative causes other than the drug that could on their own have caused the reaction? The doctor has to actively investigate the laundry detergent, the underlying disease, the viral infections. For every question on the Naranjo scale, the physician answers yes, no, or do not know.
And then they tally it up.
Each answer assigns a weighted point, value positive points if it incriminates the drug, negative points if it points to innocence, and 0 if it's unknown. You tally the points for a total score out of a possible 13.
And how do we interpret the final score? It's like a credit score for drug guilt.
A total score of 9 or higher means it is a definite ADR. The evidence is overwhelming. The drug absolutely caused the harm. Score of 5 to 8 means it is a probable ADR. The drug is the most likely culprit, but we lack absolute, irrefutable proof.
What about lower scores?
A score of 1 to 4 means it is a possible ADR. It could be the drug, but there are equally viable alternative suspects. And a score of 0 or less means it is a doubtful ADR, the drug almost certainly had nothing to do with it. Look for a different cause.
That makes the murky waters of medicine feel much more objective. But causality blaming the drug isn't the only thing the hospital administration cares about, is it? The clinical framework also emphasizes something called a preventability assessment.
Yes, utilizing tools like the Schumacher and Thornton scale. This is crucial for fixing systemic hospital errors. This assessment doesn't ask, did the drug cause the harm? It asks a much more painful question. Could we, the medical staff, have prevented this harm from happening in the first place?
How does that scale categorize the hospital's actions?
Into 3 stark categories. First, definitely preventable. This means there was a clear, documented lapse in clinical care. The wrong drug was dispensed by the pharmacy, a massive overdose was incorrectly calculated, or a drug was injected even though the patient had a blazing red allergy warning permanently stamped on their medical chart.
That's the category of pure, devastating human error. Second, probably preventable. The ADR could likely have been avoided with more careful, diligent clinical management. For example, prescribing a toxic drug but failing to order the required weekly blood test to monitor the patient's liver enzymes, or failing to check for complex interactions with the patient's existing 12 medications.
And the third,
Not preventable. An ADR that was simply unpredictable or biologically unavoidable with current medical knowledge. If a perfectly healthy patient takes a standard dose of an antibiotic for the first time and drops into anaphylactic shock or suffers a bizarre idiosyncratic liver failure, the hospital did nothing wrong. The goal of this preventability scale is to identify the first 2 categories of human errors and implement systemic safety protocols, barcode scanning, and computer alerts to stop them from happening again. Okay, so let's zoom out to the macro level again. The local hospital spots the ADR. They assess causality with the Naranjo scale, finding it probable. They assess preventability. They send the report up the chain to the national regulators at the CDSCO or the FDA, and it goes into the Vigibase supercomputer. What are the actual real-world consequences of this data? What regulatory actions can an agency actually take to protect the public?
regulators have a graduated ladder of responses depending on the severity and frequency of the safety signal detected in the global data.
Yeah.
The lightest touch is issuing safety alerts, sending direct warnings to doctors and pharmacists worldwide to be on the lookout for a specific reaction.
That seems pretty mild.
If the signal is stronger, they enforce label changes. They legally force the pharmaceutical manufacturer to update the drug's packaging with severe black box warnings or add new contraindications, like explicitly stating, "Do not take if pregnant or nursing."
What if a warning label isn't enough?
They escalate to dose modifications, legally lowering the maximum allowable dose or restricted indications. They might say, this painkiller is too toxic for general use. It can now only be prescribed for terminal cancer pain and nothing else. If there's a manufacturing error, like contamination, they initiate a rapid product recall to pull a specific batch off shelves.
And the nuclear option.
The nuclear option is full drug withdrawal, permanently revoking the drug's approval and banning it from the market entirely because the global data proves that the risks of the chemical far outweigh any possible therapeutic benefit.
And the clinical notes provide some major historical examples of these regulatory actions. We already talked about thalidomide, which was globally withdrawn due to causing severe birth defects. Though interestingly, it notes that science is wild, and thalidomide was actually later reintroduced with incredibly strict, highly regulated controls for treating leprosy and multiple myeloma, utilizing its exact mechanism of stopping blood vessel growth to starve tumors.
Yes, a drug that is a teratogenic poison to an embryo can be a lifesaver for a cancer patient. But there are many examples of permanent withdrawals. Rofaxib, heavily marketed as Vioxx, was an incredibly popular arthritis painkiller. It was withdrawn globally because post-marketing active surveillance eventually revealed a significantly increased risk of severe cardiovascular events, massive heart attacks and strokes that weren't fully apparent in the initial trials. Cisapride, a drug for severe heartburn, was withdrawn due to causing fatal cardiac arrhythmias.
And there's one more listed, Surivastatin.
Surivastatin was a cholesterol-lowering drug. It was pulled from the market because pharmacovigilance networks detected an unacceptably high rate of rhabdomyolysis, a terrifying condition where skeletal muscle tissue rapidly breaks down, floods the bloodstream with muscle protein, and completely clogs and destroys the kidneys, leading to fetal renal failure.
It's vital to remember that these weren't shady chemicals made in a bathtub. These were FDA-approved, heavily researched, aggressively marketed pharmaceuticals prescribed by thousands of doctors. They were only caught after the fact by the invisible safety net of the pharmacovigilance system.
Which is exactly why the system is the most important unsung hero in modern medicine.
All right, we have covered an immense amount of pharmacological theory, bizarre biological mechanisms, and global bureaucratic structures. Let's bring all of this crashing down into reality. Dr. Manoj's clinical presentation provides an exact real-world case scenario to demonstrate how a physician processes all of this at the bedside. Let's examine the case of Mr. K.
Yes, a perfect encapsulation of a routine yet critical day in pharmacovigilance. Let's look at the patient profile. Mr. K is a 58-year-old male. He presents to the hospital's outpatient department. He has a known clinical history of hypertension, high blood pressure, which he has been managing for the last 2 years.
Okay, a very standard patient. Millions of 58-year-old men have high blood pressure. What is the suspected chemical agent?
His physician had recently started him on a new medication to better control his blood pressure. Tablet amlodipine, a standard 5 milligram dose, taken orally once a day. Amlodipine is a very common calcium channel blocker. It works by relaxing the blood vessels so the heart doesn't have to pump as hard.
And what was the adverse clinical event?
On exactly day 9, after starting the amlodipine therapy, Mr. K developed sudden, severe, red, highly itchy rashes distributed extensively over both his arms and his entire trunk.
The clinical file actually includes a photograph of the patient's arm. It is covered in a really angry, raised maculopapular rash. It looks incredibly uncomfortable.
It does. But crucially, the attending physician's clinical notes state that upon examination, Mr. K had no fever, and he reported absolutely no breathing difficulty or wheezing.
Why are those negative findings so important? Why does the doctor care that he doesn't have a fever?
Because it dictates the immediate triage. By confirming there is no fever, no airway constriction, and no drop in blood pressure, the physician immediately rules out a systemic, life-threatening type B anaphylactic shock and rules out severe systemic inflammatory syndrome, like DRESS syndrome. It isolates the symptom to a localized cutaneous hypersensitivity reaction. It's bad, but he's not going to die in the next 5 minutes.
Okay, so the doctor diagnoses a severe drug rash. What is the management plan?
They follow the emergency flow chart perfectly. Step 1, recognize the toxidrome. Step 2, stop the offending drug. The amlodipine was discontinued immediately. This is our clinical D challenge. The doctor then moved to step 3, assess and support, providing symptomatic relief by prescribing tablet levocetirizine, a strong antihistamine, for 3 days, and applying topical calamine lotion to soothe the severe pruritus or itching.
And the clinical outcome?
The condition rapidly improved following the withdrawal of the amlodipine. The patient recovered completely within 3 days, and the maculopapular rashes subsided entirely.
Did the doctor attempt a re-challenge to prove it was the amlodipine?
No re-challenge was done. The risk of triggering a much worse immune response was unnecessary. The patient's hypertension was managed with a different class of drug, and he was strictly advised to avoid amlodipine and similar calcium channel blockers in the future.
Okay, so we have a successfully resolved case. The patient is safe. Now let's put on our clinical detective hats and calculate the formal causality using the Naranjo scale, exactly as it's broken down in the presentation's analysis. Let's interrogate the data.
Let's run the algorithm. Question 1. Are there previous conclusive reports on this reaction? The physician checks the medical literature. Yes, hypersensitivity rashes are a known, documented, albeit uncommon, reaction to amlodipine. That assigns +1 point.
Question 2. Did the adverse event appear after the suspected drug was administered? Yes, the timeline is clear. The drug started on day 1, the rashes appeared on day 9. That assigns +2 points.
Question 3. Did the adverse reaction improve when the drug was discontinued? Yes, the rashes subsided completely within 3 days after stopping the amlodipine. We have a highly positive D challenge. That assigns +1 point.
Question 4. Did the reaction reappear when the drug was readministered? We just established that no rechallenge was done. It was deemed too risky. Therefore, the answer is do not know. That assigns 0 points.
Now for the critical question 5. Are there alternative causes that could have on their own caused the reaction? The physician investigated. No new soaps, no new foods, no viral symptoms, no other new medications. All alternative clinical causes were ruled out. Because the answer to are there alternative causes is a definitive no, The algorithm heavily rewards the probability of the drug's guilt, adding +2 points.
Skipping through a few neutral questions involving placebos and drug levels where the answer was do not know, we land on question 10. Was the adverse event confirmed by any objective evidence? Yes, the physician physically examined and photographed the rash. It wasn't just a subjective feeling reported by the patient. That assigns +1 point.
So we synthesize the data. +1 for literature, +2 for timeline, +1 for D-challenge, +2 for ruling out alternatives, +1 for objective proof. The total score is 7 out of a possible 13.
And based on the interpretation scale we establish, a score of 7 firmly lands Mr. K's case in the probable ADR category. The clinical conclusion is that the reaction is a probable adverse drug reaction, highly likely related to the tablet amlodipine 5 mg.
Exactly. The local hospital files the report, it travels to the CDSQO and on to Sweden. The lesson highlighted here by the clinical team is that even incredibly common, seemingly benign maintenance drugs like amlodipine drugs taken safely by millions can unpredictably trigger severe hypersensitivity reactions in a specific biological environment.
That's a sobering thought.
The mandate for physicians is be profoundly alert, document everything, report every ADR, because active reporting is the only mechanism that improves global patient safety.
It is a perfect textbook case of how the detection and reporting system is supposed to work. But Dr. Manoj's clinical breakdown doesn't just look at how we manage the present. It looks at the horizon.
Yes, the future of pharmacovigilance, because frankly, relying on exhausted doctors to manually fill out paper forms and calculate Naranjo scores by hand is a 20th century solution to a 21st century data problem.
How is this global detective network evolving?
The network is undergoing a massive technological revolution. First, they're increasingly deploying artificial intelligence and natural language processing. Instead of waiting for a form, AI algorithms can read millions of unstructured, digitized doctor's notes in real time.
So it stands for red flags.
It instantly flags keywords like rash, amlodipine, and D-challenge, automatically generating safety signals without a human ever filling out a report.
They also highlight big data analytics plugging the Vigibase directly into massive national health insurance databases and electronic health records to proactively scan for hidden toxicities across entire populations. And mobile ADR reporting, which seems incredibly simple but highly effective. Smartphone apps that allow a nurse, a pharmacist, or even the patient themselves to report a severe side effect directly to the national database with a few taps on their phone.
Democratizing the data collection is huge. But the absolute most exciting revolutionary advance on the horizon is the integration of pharmacogenomics.
Let's circle back to that because we touched on the magic of DNA earlier with the idiosyncratic liver failures and the G6PD deficiencies. Pharmacogenomics is the ability to predict a patient's risk of an ADR based entirely on their specific genetic variations before they ever touch the pill.
Yes, it is the holy grail of personalized medicine. We know that the cytochrome P450 enzymes in the liver dictate how drugs become toxic. In the near future, instead of prescribing a standard adult dose based on the average population, a physician will routinely run a rapid genetic sequence of your specific liver enzymes.
And the computer will just know.
The computer will analyze your DNA and tell the doctor, do not prescribe warfarin to this patient. Their CYP2C9 enzyme is genetically deficient and they will hemorrhage. Prescribe this other drug instead.
We have covered a staggering, mind-bending amount of ground today. We started by untangling the vital semantic differences between an adverse effect, a broad, drug-centered, unintended consequence, and an adverse drug reaction, which is a specific noxious harm happening specifically to your biology. We explored how those reactions can escalate into physical trauma, known as an adverse drug event.
We deeply examined the anatomy of vulnerability, learning the pharmacokinetic realities of why a shrinking kidney, a higher percentage of body fat, or a massive polypharmacy traffic jam in your bloodstream drastically alters your risk profile. We walked through the Rollins and Thompson ABCs from the predictable dose-dependent augmented type A insulin crashes to the terrifying, unpredictable Ig-mediated immune explosions of bizarre type B allergies.
We looked at the incredibly precise molecular lock and key mechanisms that emergency rooms use to reverse toxicity, how NAC builds liver shields, how naloxone acts as a biological battering ram in the brain, and how chelation claws trap heavy metals. We explored the surreal reality of UV photons turning antibiotics into cellular bombs in phototoxic reactions, and the tragedy of physician-induced iatrogenic diseases that persist long after the prescription runs out. And finally, we followed the trail of data from a single hospital clinic treating Mr. K's rash all the way to a global supercomputer in Sweden, watching the Pharmacovigilance network calculate causality and protect the public.
It is a phenomenal, highly complex, largely invisible ecosystem that protects millions of human lives every single year.
So, we want to leave you with a final thought to mull over. We started this deep dive talking about the X ray machine, how we inherently want medicine to be precise, visible, perfectly clean, and entirely predictable. And through this clinical breakdown, we discovered that the reality of prescribing synthetic chemicals is actually incredibly murky. It is full of trial and error, undiscovered genetic mysteries, cascading drug interactions, and unpredictable immune system landmines.
The margin for error is razor thin, and the biological variables are nearly infinite.
But the future is pointing us right back toward precision. Building on that incredible concept of pharmacogenomics, what does this all mean for you, the patient? Next time you look at a medicine bottle, consider that we are rapidly approaching an era where the concept of trial and error prescribing might disappear entirely. Imagine a very near future where, before a doctor even considers writing a script, they scan your unique DNA. They bypass the idiosyncratic liver failures, they avoid the bizarre allergic cascades, and they perfectly calibrate the narrow therapeutic index before you ever swallow a single pill, because they already know exactly, down to the molecule, how your body will react. The ultimate X-ray machine for out-of-drug reactions is being built right now, and it's written in our DNA.
But until that day arrives, until the technology is in every local clinic, your absolute best defense is your own vigilance and your own voice.
Pay close attention to your body. Ask your doctor about the therapeutic index of your medications. Understand your risks. And most importantly, do not be afraid to report what you feel. If a drug makes you sick, tell your doctor. You aren't just complaining about a nuisance. Your specific biological reaction might be the exact data point that travels to a computer in Sweden, triggers a safety signal, and saves someone else's life. Stay curious, stay informed, and stay safe.